Hello, this is Michael Altos. We are continuing neuromuscular blocking agents and reversal drugs. This is recording part 3.
Before we discuss reversal of non-depolarizing neuromuscular blocking agents, I'd like to spend a moment talking about the importance of avoiding residual neuromuscular block. Our goal is to achieve a train of 4 ratio of greater than 0.9. And so the question may come up, should we consider ever not reversing a patient who's been given non-depolarizing neuromuscular blocking agents? The short answer is only if you can show that the train of 4 ratio is greater than 0.9. In order to do that, you need a quantitative train of 4 monitoring device. Otherwise, the recommendation is to use at least some reversal. Now, I suppose if many hours have passed since the last dose of neuromuscular blocking agent, I don't know, maybe 6 or 8 hours or more, you might consider giving no reversal. It really depends on your dosing and the pharmacokinetics, and as we use multiple doses and longer acting agents, we really need to have more and more caution. For example, one study showed that 3 hours after the last dose of rocuronium, 21% of patients still did not have a train of 4 ratio greater than 0.9. Now let's just be clear, I'm not advocating a medical legal dose, whatever that means. This is pharmacology, and it's evidence-based patient care. If you can show that the ratio is greater than 0.9, then you are justified in not giving a reversal agent. Even when the train of 4 ratio is only 0.7 to 0.75, which to your finger or to your eye is identical to a ratio of 0.9, unless you're using a quantitative monitor, patients may look strong. They can have sustained head lift and cough sufficiently, yet they still have residual neuromuscular blockade at this level of train of 4 ratio. So why is this important? Because the consequences of even minor degrees of residual block include weakness of upper airway muscles and airway obstruction, increased risk of aspiration, unpleasant sensations of muscle weakness, prolonged recovery room stay, hypoxemia, and even awareness during emergence from anesthesia, or increased postoperative pulmonary complications like atelectasis or pneumonia. One study even showed that raising the threshold for extubation from 0.9 to 0.95 was associated with a still lower incidence of postoperative pulmonary complications. So this is something that we really need to take seriously. And that means using proper quantitative monitoring, avoiding monitoring at the facial muscles whenever possible, instead monitoring at the adductor pollicis at the thumb, and certainly ensuring proper electrode placement and avoiding direct muscle stimulation, which could look like nerve stimulation.
Now we're going to talk about reversal agents. The most commonly used drugs are cholinesterase inhibitors. They inhibit acetylcholinesterase, and some people call them anticholinesterases. The common ones are neostigmine, pyridostigmine, edrophonium, and physostigmine. All of these drugs have the same basic principle. They indirectly increase the amount of acetylcholine in the neuromuscular junction, and the acetylcholine can then compete with the non-depolarizing neuromuscular blocking agent. These drugs reversibly bind to the acetylcholinesterase enzyme, and there may be some other mechanisms as well, some presynaptic actions or some non-acetylcholine mediated actions as well. Reversal agents are organophosphates, the same thing that some pesticides are made out of. Also nerve gases like sarin nerve gas that have been used in some terrorist and chemical warfare attacks. Organophosphates can also be used to help diagnose and treat myasthenia gravis, which is a disease we'll speak about a little bit later. In excessive doses, acetylcholinesterase inhibitors can actually cause weakness due to acetylcholine-mediated blockade. And many sources recommend that if a patient has almost completely recovered from their neuromuscular blocking, they should get a decreased dose of reversal agents. So don't think that these agents always cause strength. They only improve strength in patients who are experiencing block from a non-depolarizing neuromuscular agent. These drugs will also cause some inhibition of pseudocholinesterase, and this would lead to a prolonged action of succinylcholine. The side effects of all of these drugs are due to the increased levels of acetylcholine. In the heart, that would be bradycardia. In the lungs, bronchospasm and secretion. In the central nervous system, you'll get some excitation, but only with the drugs that cross the blood-brain barrier, and that would be physostigmine. You will also see meiosis or papillary constriction. In the GI system, nausea, vomiting, GI activity, salivation. And the acronym that I've learned is Mr. BB Sludge. The meiosis and the rhinorrhea, the salivation, lacrimation, urination, defecation, GI upset and emesis, and the BB is for bradycardia and bronchoconstriction. The side effects that we have just described can be treated with an anticholinergic agent, something that blocks the action of acetylcholine, like glycopyrrolate or Robinol. This drug does not cross the blood-brain barrier, compared with atropine, another anticholinergic agent, which does cross the barrier. The drug is cleared by the liver and the kidneys. In order to reverse a patient who's received a non-depolarizer, there must be some evidence of spontaneous recovery. So if their train of 4 ratio is 0, if they have no twitches at all, rather, if they have no twitches, the patient is not reversible. Even if there's a post-tetanic twitch, the chances that you'll have a successful reversal using an anticholinesterase is extremely low. If the patient has 1 or 2 twitches, they may be difficult to reverse, but you can try. If they have 3 twitches or 4 twitches but with some fade, they should receive a full reversal dose. And if they have 4 strong twitches with no evidence of fade, then you can consider giving a partial reversal dose. I would usually give half of the full dose. If the patient actually can show you sustained 5-second tetanus or clinical evidence of adequate strength, then a partial reversal dose or even no reversal may be appropriate. This really depends on when you last gave the drug, how much you've given, and certainly with a longer acting agent, you'll usually err on the side of giving some reversal. Studies show that when you have 4 twitches and you can't see any fade, which means your train of 4 ratio is about 0.7 to 0.75, you may have a patient who can do a sustained head lift, they can cough, and so to you it looks like they're strong, but in fact they still have impairment of the muscles of their pharynx and their esophagus. They have increased risk of regurgitation or aspiration or airway collapse, some atelectasis, and this all may still occur until their train of 4 ratio is greater than 0.9. And the difference between 0.7 and 0.9 is really something we can't see with our eyes or feel with our fingers. So if there's any question, you should always give some reversal. A half dose may be appropriate, but there are times when no reversal dose could be considered. Edrophonium is actually a faster reversal agent than neostigmine, and as you increase dose, you speed reversal too. We expect that shorter acting agents reverse faster than long acting agents, and patients who have severe end organ disease like renal or hepatic failure may have prolonged block and also be more difficult to reverse. The main reversal drug in this category is neostigmine, with a dose of 0.04 to 0.08 milligrams per kilogram. The maximum dose is usually considered to be 5 milligrams in adults. Many people use the shortcut of 1 milligram per 20 kilograms of body weight. It should be given together with glycopyrrolate, and the normal ratio is 0.2 milligrams of glycopyrrolate per 1 milligram of neostigmine. The effects of neostigmine take about 5 minutes to work, although the peak is at 10 minutes and it lasts for about an hour. Neostigmine may cross the placenta, and so in pregnant patients you may want to consider using atropine instead of glycopyrrolate, so it could also cross the placenta and prevent fetal bradycardia. Pyridostigmine is available. It has a longer onset and a longer duration, but I haven't seen it routinely used. Edrophonium does have a more rapid onset of action of just 1 to 2 minutes. It also has a shorter duration of effect, and most people recommend using atropine instead of glycopyrrolate with it. There's a better match with its onset and its duration. Physostigmine is a little bit different than the others. First of all, it's a tertiary amine, which means it is uncharged and it crosses the blood-brain barrier. It's also used as the treatment for central anticholinergic toxicity, which can be precipitated by a number of different drugs. It may reverse some CNS depression or delirium that people have after volatile anesthetics or benzodiazepines, and some have used it for the treatment of delirium in the PACU. It also happens to be an effective treatment for shivering postoperatively at a dose of 0.04 milligrams per kilogram. When it's used for any of these indications, we usually don't give atropine or glycopyrrolate together with it, but it should be available in case the patient experiences some of those Mr. BB sludge symptoms that we described before. Physostigmine is metabolized by plasma esterases, but not pseudocholinesterase. We now have a recently newer player in the market of reversal agents, and that's Sugammadex, Bridion. It selectively binds to rocuronium as well as vecuronium and pancuronium to some degree. It's made of a designed cyclodextrin ring which binds tightly, although not irreversibly, to the rocuronium. It does not bind at all to the benzyl isoquinolines. It needs that steroid nucleus, so therefore it will not work at all on atracurium, cisatracurium, mivacurium. It is remarkable for its ability to reverse even very deep neuromuscular blockade. So much so that you could use it with rocuronium for a rapid sequence induction instead of succinylcholine. The dose is normally 2 milligrams per kilogram if the patient has 2 or more twitches on train of 4. You can use 4 milligrams per kilogram if they only have 1 to 2 post-tetanic twitches. But the dose can go all the way up to 16 milligrams per kilogram, and that will be effective for immediate reversal of even the highest levels of blockade. For example, 1.2 milligrams per kilogram of rocuronium can be reversed immediately with this high dose of Sugammadex. Adverse effects include anaphylaxis, which has been reported more commonly at high doses like the 16. Bradycardia has been described. It may interfere with the action of hormonal contraceptives, and most recommendations are that patients who are taking hormonal contraceptives should use an alternative form of birth control for at least 1 day, and some recommend 7 days. We also don't recommend using Sugammadex in patients with severe renal disease or who are on dialysis, because they may have impaired clearance of this drug. Now we're going to speak about a few other diseases that can affect the muscles of the body. The first is myasthenia gravis. These patients have antibodies to their acetylcholine receptors. And those antibodies block the ability of acetylcholine to activate the receptors, and the patients become weak. In these patients, when you give succinylcholine, they tend to be resistant. Again, because the succinylcholine is competing against these antibodies, which are occupying the acetylcholine receptors. But if the patients are being treated with pyridostigmine, so if you think about it, pyridostigmine is an anticholinesterase. It increases the amount of acetylcholine in the neuromuscular junction, and it would be an effective treatment to compete against these acetylcholine receptors that are blocked by the antibodies. So if a patient is being treated with pyridostigmine, and then you give them succinylcholine, the pseudocholinesterase activity may be reduced by the pyridostigmine, and they'll have a prolonged metabolism of succinylcholine. So really, in general, we say that they're resistant to succinylcholine, but the meds they're taking may actually cause them to be extra sensitive to succinylcholine. As for non-depolarizing agents, they tend to be sensitive, probably because they already have weakness, and you're adding another weakening drug to them. It may be difficult to reverse them because of the pyridostigmine they're already taking. In my practice, I try to avoid giving them neuromuscular agents when possible, but that isn't always feasible. And while you should know about resistant to SUX and sensitive to non-depolarizers, because that's a very boards-oriented type of question, I've seen patients do the opposite when they have myasthenia gravis. So just be careful with these drugs. Start slowly and give more as needed. Myotonia describes many different types of conditions where patients have an abnormal delay in their muscle relaxation after contraction. In these patients, if you give them succinylcholine, they may have a sustained muscle contracture and have hyperkalemia, but we expect a normal response to non-depolarizers. Reversal agents may be a problem in these patients, as they can develop a myotonic response when they have the increased levels of acetylcholine. I would imagine that Sugammadex would be the best choice in these patients. Muscular dystrophy, of which there are many types, refers to a loss of muscle mass. These patients, as we've said before, may have upregulation of their acetylcholine receptors throughout the cell membrane, and when they get succinylcholine, they could have a sudden fatal hyperkalemic cardiac arrest. And patients who are young, especially males who are less than 10 years old, may have yet undiagnosed disease, which is one of the reasons that some pediatric anesthesiologists try to avoid succinylcholine in young male children. These patients should have a normal response to non-depolarizers. Upper motor neuron lesions, like patients who are hemiplegic or quadriplegic, these patients, as we've said before, can have upregulation of their acetylcholine receptors, and succinylcholine can cause hyperkalemia. Again, this starts 2 to 4 days after the injury, so before that time it's safe. But once you've hit the 48-hour mark, we avoid succinylcholine, and this effect can continue for anywhere from 6 to 24 months. Interestingly, these patients may have resistance to non-depolarizers below the level of the lesion. Burn patients also have proliferation of these extrajunctional acetylcholine receptors. So succinylcholine, again, will cause hyperkalemia, starting 2 to 4 days after the injury and lasting for at least 12 months. Again, these patients will also be resistant to non-depolarizing agents. That wraps it up for our discussion of neuromuscular blocking agents and reversal agents. Please let me know if you have questions about any of this material.